Airway Troubleshooting for the sports medicine examination. I'm Neil Dilworth, and we'll be going over both a number of scenarios and a walkthrough plan as to how you will deal with those when they come up in the exam. Call this Airway Troubleshooting 101. This image is used to just essentially demonstrate how straightforward the anatomy is from an airway perspective, not to undervalue how important it is to be aware of a number of different things that can cause obstructions, but that there really are just essentially three ways into the airway. One is through the nasal passage, so things like a nasal pharyngeal airway. Secondly, through a oral passage, oral pharyngeal airway. And then thirdly is a cricothyroidotomy or a surgical tracheostomy. Obviously, we wouldn't be doing a surgical tracheostomy, and hopefully we never have to do a cric. But once again, if you're thinking about that, that's something you're probably going to have to do if you're considering it. So once again, those are really the only ways of entering into the airway. A couple other things to consider. So in terms of nasal pharyngeal airway, obviously any kind of facial fractures is going to block that. Similarly with the oral pharyngeal, also a mandible fracture can occlude that, as well as what we commonly see in sports events are gum shields or mouth guards that can get caught in here. These are things that can be easily removed to help troubleshoot an airway. Further down, a patient or player is unconscious. Their mass of the tongue can essentially sit back. So either a head-jaw tilt, which is demonstrated here, or a jaw thrust, which is essentially grabbing the corner of the mandible up away from the patient, can help bring the tongue away from the posterior pharynx and larynx and open up that airway. So the first way I'd like you to think about the scenario is if you had no equipment. So you're on the side of the field and you see a player get into a collision and they're grasping at their airway in terms of a choking sign, and you don't have any equipment. What kind of things can you do? So I broke it down into three potential mechanisms that you can use to approach the patient. Number one is to clear the airway, like we talked about, so removing equipment, whether that's a face mask or doing a finger sweep to remove a mouth guard or gum shield. The position, so checking the position, so like we talked about, doing a jaw thrust if there are C-spine precautions, as there often are in sports injuries. And if there is no C-spine precaution, it's just an airway issue, then you can do a chin tilt lift to help essentially improve the airflow through the airway. And then finally, ventilation. So you've done trying to clear the airway and you've modified the position and you're still having difficulty, you can actually give some forced breaths either via the mouth or the nose. Number two, you have equipment. So what equipment are you going to use? So you've gone through all the procedures in the no equipment phase. We use the mnemonic short of breath and then epi. So short of breath stands for suction, oxygen, bag valve mask, and then the epi is for epinephrine, for an anaphylaxis airway. And there's two ways of thinking about the adjunct equipment. Then is the adjunct equipment for the upper airway, which is essentially your nasal passage and the oral pharyngeal passage, and then B, the lower airway, which gets down into the larynx, or in fact doing a cricothyroidotomy. So your upper airway, you can put a nasal trumpet in or a nasal pharyngeal tube. which will essentially allow for airflow from the outside of the air to get down to the back of the pharynx. If there's any kind of occlusion in the mouth, like such as a mandible fracture, that's an ideal situation. Generally speaking, you're not putting those in unless a person is unconscious and they don't have and their gag reflex is obviously absent at that stage. And similarly with an oral pharyngeal tube, not generally going to put that in if there's any level of consciousness. You're going to that's going to be put in when the player is on the field and they're unconscious. For measurement of the oropharyngeal airway, that goes from the tragus of the ear to the opening of the lips, and that's how you measure out which oropharyngeal airway you would use. So generally speaking, these would be for adults, and then the last four are for your pediatric population. Contraindications, so we talked about it before. If your patient's CT scan looks like this, this is a contraindication to doing a nasopharyngeal airway or a oropharyngeal airway, and you could apply supplemental oxygen on this patient. But if there's difficulty with air movement with this level of facial fracture or a facial fracture, generally speaking, you're going right to the lower airway, and you want to be considering, once again, if you're thinking about it, do it, and you'd be considering a cricothyroidotomy and preparing for that. So for the lower airway, there's a couple of things that will go through the oral passage, such as a laryngeal mask airway, or a King LT, or in fact an endotracheal tube, which would be a definitive airway. And then finally, if there is any kind of emergent situation where you need to be able to oxygenate the patient, once again, if you're thinking about it, you need to do it, and say it for the exam: cricothyroidotomy. Case number 1, hockey player on the ice, they're unconscious after being hit into the boards. They have you have no equipment on hand, and the play has stopped. You step out onto the ice and you go to assess the patient. Player is unconscious, not moving, pulse is present. Go. So what you want to do in this situation is think about what you need to do, is there anybody you want to call, and how you're going to proceed. So in this situation, you want to first essentially make sure the C-spine precautions are met, and because the patient would be lying prone, or the player is lying prone, you get the team members to essentially help log roll the patient over, and then you want to have the C-spine secured so you can remove the mask. The first step after clearing the equipment would be then to do a finger sweep and clear the airway. And in this situation, that would essentially be the solution to this case. In an exam setting, you would then continue to provide supportive measures. So oxygen, perhaps doing a secondary survey of the patient, getting blankets to keep the patient warm, checking pulse oximetry, blood pressure, and so on if you had equipment available. Obviously, you want to activate your emergency action plan early in these situations. So when you see that a patient is lying and not moving in that situation, you would want to essentially activate your emergency action plan upon seeing the player lying down. Case number 2, football player unconscious after tackled while receiving a punt. His neck snaps back before the player hits the ground. He's lying unconscious on the field, and his helmet is still on. So for this scenario, you have full equipment, you have a full team. Once again, you see a rather significant hit, and you see the player lying on the ground. Once again, you want to be thinking about what you want to do next, who you want to bring with you, what kind of equipment you would like to bring with you, and making sure that that field is safe and secure before you go onto the pitch or onto the field. So you get out there and the patient still has a helmet on, there is a pulse present, okay? The mask is still on, so to access the airway, which is obstructed in this case, feel that the patient isn't breathing or moving air, first thing you want to do is essentially remove the helmet, or in this case you can even just get away with removing the face mask and then doing a finger sweep to remove the mouth guard. So you do that, still there's not much air being moved. You try a jaw thrust because there's a C-spine precaution, and once again no airway gets moved. Then you try in fact ventilating, and you give a couple of breaths and you're not feeling any air goes in. So next thing you try and get an OPA, and you realize that you can't actually get the mouth open enough. The mouth is fixed, and it in fact looks like the jaw is dislocated. So you try a nasal pharyngeal airway and try ventilation, and nothing. And then you try a bag valve mask to add to your ventilation, as well as some oxygen and suction, and you get some minimal movement. What are you thinking about at this stage? So the jaw seems off center, you're unable to move mouth much to fit either an LMA or an ET tube in. You've tried a nasopharyngeal airway, tried a bag valve mask. What are you thinking about next? There's nasal, there's oral, and then there's lower. If you're thinking of it, say it and do it. So you're thinking about it doing a cricothyroidotomy. That's where this is a situation where you were prepared to do that. So bringing out your cric kit, landmarking, putting in some local with epi, and essentially puncturing in between the cricothyroid space, and then essentially attaching high flow oxygen. And that'll buy you about 30 to 40 minutes time to get the patient a surgical airway. So in summary, you want to use all the no equipment techniques for patients. So that's clearing the airway, that's checking that position, so whether you're doing a jaw thrust or a head chin tilt, and providing accessory ventilation by giving breaths. And then you want to work through your upper airway, so both your nasal and oral pharyngeal airway, with your shortness of breath adjuncts and epi. So if you feel that there's a lot of swelling, you obviously want to give epinephrine, 0.3 to 0.5 milliliters of 1 to 1,000 epinephrine, or otherwise it's suction, oxygen, and bag valve mask. And if that upper airway is still blocked, then you're going down lower airway. If you can't get any lower airway equipment in, such as an LMA or a King LT or an endotracheal tube, you're doing a cricothyroidotomy. Thank you very much.